I would like to thank Novartis and Al-Qasimi Hospital for giving this opportunity to discuss a very important talk, which is diabetic eyes. And my name is Dr. Noor Al-Mansouri. I'm a vitreoretinal surgeon here in Abu Dhabi and medical director of Samaya Specialized Center. And today our talk will be about a very important topic to our country, because we have plenty of diabetic patients and we would like to know more about managing those diabetic eyes. And Dr. Firas Jalouk, our dear colleague, and he's a vitreoretinal consultant here in Mediclinic Abu Dhabi, and he will start his talk about this important topic. The floor is yours, Dr. Firas. You can start your presentation, please. And I would like to remind all the audience to put their questions in the question and answer column, so we will answer them at the end of the presentation. You can start, Dr. Firas. Thank you. Hello, Dr. Firas.
Hello, هتسمعيني؟
Hey, أسمعك. Yes, I can hear you, Doctor.
طيب كان في مشكلة Okay. So you can hear me now then?
Yeah.
Okay, thank you very much. Thanks everybody. Thanks for Novartis for inviting us to talk about diabetic retinopathy and treatments. First of all, just going to talk about diabetes is a growing, as everybody knows, is a growing worldwide epidemic affecting mostly the working age population in our area. It accounts for over about 25% of the population are affected by diabetes. Diabetes in the future. So in year 2017, 425 million adults living with diabetes. 30% of them, they have diabetic retinopathy. That's about 127 million. Now in 2045, it's expected to that number to go up to 188 million, as diabetic population is expected to be 629 million. While the more severe cases, as in diabetic retinopathy, that threatening the vision, is now about 10% of the diabetic population, which is about 12 million. But in the year 2045, it's expected to be about 18 million. Now, the disease burden, diabetic retinopathy is a leading cause of blindness in working age adults in the developed countries. And proliferative diabetic retinopathy and diabetic macular edema are the main cause for these loss of vision. The pathophysiology for this, so diabetes that will cause obviously hypoglycemia, and in eyes that will lead to inflammation and VEGF's production, and that would lead to microaneurysms in diabetic retinopathies, while in the body that would lead to macrovascular diseases. Now, diabetes and visual loss. The diabetic retinopathies that would cause a breakdown in the blood-retinal barrier, and neovascularization and microaneurysms that would lead to leakage. So macrovascular changes, structural functioning changes in various parts of the eye. So macrovascular changes that would lead to hypoxia and increased release of VEGFs that would lead to neovascularization and maybe visual loss. And all macrovascular changes might cause leakage, and that would lead to macular edema, which may cause loss of vision as well, as we mentioned before. Now, clinical features and complications. Diabetic retinopathy is a common progressive microvascular complication of diabetes and is a precursor to diabetic macular edema and proliferative diabetic retinopathy. Non-proliferative diabetic retinopathy, it could be characterized as mild, moderate, or severe. Mild, as everybody knows, is characterized by microaneurysms only, while moderate, there will be Hermes and macroaneurysms, where severe, it's when widespread intraretinal hemorrhages, microaneurysms are observed. Now, proliferative diabetic retinopathy, that it's characterized by retinal neovascularization, and those new blood vessels are likely are either to be localized at the optic discs or elsewhere, and those new blood vessels are likely to be fragile, which may rupture and cause hemorrhage. The other things those might cause that they might keep growing and might block the angle of the eye, which may cause a neovascular glaucoma as well. Now, clinical features and complications. 50% of people with very severe non-proliferative diabetic retinopathy progress to proliferative diabetic retinopathy within a year, and 25% of patients have PDR at 15 years of diabetes duration. So NPDR, as we mentioned before, it's macroaneurysms, intraretinal hemorrhages, vascular changes, hard exudates, soft exudates, or cotton wool spots, intraretinal microvascular abnormalities, ERMEs, retinal edema, where PDR is neovascularization with possible complication, as we mentioned in the slide before, vitreous hemorrhages, fibrosis, which may lead to tractional detachments or neovascular glaucoma. The visual loss can occur as diabetic retinopathy worsens from NPDR to PDR. As diabetic retinopathy progresses, abnormal blood vessels growth mediated by VHFs occurs. The new vessels are fragile, as we mentioned before, prone to hemorrhage. The retina and visual complications of NPDR is typically asymptomatic. However, if the macula is not involved, however, a comprehensive eye exam will reveal blood vessels that supply the retina to be swollen and distorted. Where retina and visual complications of PDR, patients will experience spots in their fields of vision as new blood vessels are fragile because of hemorrhage, basically, and PDR is associated with high risk of visual morbidity arising from tractional retinal detachment. So diabetic retinopathy severity scale, that's the ETDRS diabetic retinopathy severity scales. It's from one, it's normal at 10, it's normal, NPDR, PDR, which is mild proliferative, moderate, high risk, or advanced. Diabetic retinopathy can worsen over time from mild NPDR to severe NPDR or vision-threatening proliferative diabetic retinopathy. So the diabetic retinopathy severity scale is broadly based on the absence of NPDR or presence of PDR of abnormal new blood vessels. It's clinically relevant measures that correlates with functional anatomical outcomes, including changes in visual acuity and retinal thickness. An increase in diabetic retinopathy severity scale level is associated with an increased risk of developing vision-threatening PDR or diabetic macular edema, and regression in the DRSS level is associated with improved visual acuity and macular edema resolution. Early treatment correlates to better visual acuity outcomes and reduces risk of permanent loss of vision. So 2 steps improvement on the diabetic retinopathy severity scale is clinically relevant as a main endpoint of analysis. Correlation of conventional classification with the numerical scale of severity of ETDRS. So mild, moderate, severe, or very severe, and that's the level you hear sometimes in all these studies. That's, I don't think we use this in our clinical practice. It's just in studies we read. So very severe is level 53 and above. Same here with the numerical scale for severity of ETDRS. So level 61 is fibrosis proliferation, neovascular, less than half of the papillary area. So ETDRS study showed that eyes with DRS are at between 47 and 53 at a highest risk of PDR. I'm just going to skip most of those because those are more relevant, and because we're pressed on time, I think most of those are relative to basically studies rather than clinical practice. So vision loss from diabetic retinopathy tends to be to affect people of working age, and complication of diabetes caused by damage of small vessels of the retina. Diabetic progression, diabetic macular edema patients is associated with better outcomes. Patients with 2 steps or more of progression over the first 4 years were 5.8 times more likely to develop progressive diabetic macular edema. So major advances in diabetic retinopathy. Timeline of major advances in 1856, description of diabetic retinopathy ophthalmoscope was first mentioned. The discovery of insulin was 1921, and the ETDRS confirms efficacy of focal laser of diabetic macular edema. That was back in 1985. The UK prospective diabetic studies showed intensive glycemic control decreased the risk of development of diabetic retinopathy in type 2 diabetes. That's in 98. And 2015, that's where the revolutionary anti-VEGF treatment started to be in practice for both diabetic retinopathies and AMDs. So clinical evidence of ranibizumab in diabetic retinopathy. Key ranibizumab trials in DME are in diabetic retinopathy, RISE and RIDE, Protocol S and I, Restore, Reveal and Refine, and PRIDE. So RISE and RIDE study objective to evaluate diabetic retinopathy outcomes with ranibizumab treatment in patients with diabetic retinopathy and diabetic macular edema at higher risk of progression to progressive disease. Study population, 746 patients with baseline fundus photographs, primary outcome measures, 2 or more steps or 3 or more steps improvement or worsening on ETDRS diabetic retinopathy severity scale, and time to new progressive event. Conclusions: intravitreal ranibizumab reduces the risk of diabetic retinopathy progression. Diabetic retinopathy improvements were rapid, clinically meaningful, and sustained through month 36. I'm just going to go through those very quickly because we're pressed in time. We're still on now. Protocol S. The objective was to evaluate the efficacy and safety of intravitreal ranibizumab versus PRP or for visual acuity outcomes in patients with progressive diabetic retinopathy. Study population was 394 patients with PDR with or without diabetic macular edema. Primary outcome measures, main visual acuity changes at 5 years. Conclusion: findings support either ranibizumab or PRP as viable treatment for patients with progressive diabetic retinopathy. Greater visual acuity gains achieved with ranibizumab monotherapy, and better visual acuity outcomes achieved with, that's basically same conclusion. Lower rates of development of diabetic macular edema observed in ranibizumab group compared with PRP group. I think this is not a surprising conclusion. 46% of patients in ranibizumab group showed reduction of 2 or more steps on the RSS at 5 years, maintaining the rates of diabetic retinopathy improvement. Protocol I. Objective was to evaluate effects of intravitreal ranibizumab or triamcinolone acetonide administered to treat diabetic macular edema. I'm not sure if anyone's still using triamcinolone intravitreally. I'm interested to hear in the discussion group. In any case, the conclusion was intravitreal ranibizumab appears to be associated with reduced risk of diabetic retinopathy worsening in eyes with or without progressive diabetic retinopathy. So ranibizumab treatment is associated with a reduced risk of diabetic retinopathy worsening in eyes with or without proliferative diabetic retinopathy. Restore, reveal, and refine. In Restore, I think that's the most common, the most well-known study. Restore, the study, the indication is diabetic macular edema and treatment diabetic macular edema in Europe, and population was 345 patients. Treatment arms, 0.5 milligrams of ranibizumab laser or combined ranibizumab and laser. 3 months loading dose and then PRN, and study duration was 12 months. The endpoint was 3 or more steps changes on ATDRS, DRSS scale at 12 months and change from baseline in the ATDRS diabetic retinopathy severity scale. Improvement in diabetic retinopathy severity scale favoring ranibizumab over laser. Treatment difference of 2 or more steps improvement favoring ranibizumab was seen in all 3 studies. The PRIDE objective was to assess efficacy and safety of ranibizumab with or without PRP compared to PRP alone in patients with proliferative diabetic retinopathy. The population is smaller than the previous study in Protocol S, but study population was 106. Primary outcome measures change in area of retina neovascularization, and conclusion was ranibizumab showed stronger effects on neovascularization, leakage, and area reduction while offering better visual acuity results than PRP. And I would like to hear from everybody, and especially Dr. Noura, about laser treatment in our real-life practice for proliferative diabetic retinopathy, if they combine laser with intravitreal anti-VEGF injection. So no difference in the LS main changes in neovascularization area between the combination and the ranibizumab groups or the combination and the PRP group. So this is the study, this is the summary of the studies. They're not run one by one against each other here on this slide, but also the good effect of ranibizumab either for macular edema or proliferative diabetic retinopathy. So in conclusion, ranibizumab treated patients were significantly more likely to improve at 2 or more on DRSS steps from baseline to month 24 compared with sham. That's in Ride and Rise. Better visual acuity outcomes achieved with ranibizumab monotherapy in patients with diabetic macular edema and diabetic in Protocol S, while ranibizumab treatment is associated with reduced risk of diabetic retinopathy worsening in eyes with or without proliferative diabetic retinopathy in Protocol I, where improvement in DRSS favoring ranibizumab over laser in 3 studies, Restore, Reveal, and Refine. Ranibizumab showed stronger effects on neovascularization leakage, neovascular leakage and area reduction while offering better visual acuity results than PRP alone that was showed in the PRIDE study. Ranibizumab has been shown to prevent progression to PDR and to improve vision in patients with proliferative diabetic retinopathy regardless of baseline in diabetic macular edema. I'm just going to show a couple of cases. I have this patient is a 53 years old male, type 2 diabetes for 15 years, never had any treatment for diabetic retinopathy, presented to our department with 3 days history, sudden loss of vision in the right eye. His visual acuity was 624 in the right eye, 612 in the left. He had right diabetic vitreous hemorrhage in the right eye and cataracts. B-scan showed flat retina, left early cataract and proliferative diabetic retinopathy with macular edema. Patients had right PRP through the what's been visible through the hemorrhage, came back for follow-up with vision being dropped to 660. So at that time, he was referred to me for non-resolving diabetic vitreous hemorrhage. So I proceeded with combined vitrectomy, epiretinal membrane peel, and I usually peel the ILM as well, and fill in PRP. At the end of the operation, I gave him Lucentis. A month later, his diabetic macular edema started to resolve. Another Lucentis was given, and patients missed 2 appointments, as diabetic patients do, and came back 2 months later, 2 months after the injection appointments with vision active 6/9. Because of the intraretinal cysts and because the patient was unreliable for follow-up, I gave him another injection. And his vision maintained 6/9 2 months after that injection. And what impressed me in this case, that ranibizumab lasted about 2 months in vitrectomized eye. Now, the other case is a 64 years old male with 20-year-old type 2 diabetes, Pathophysiology, presented to our clinic with 1 month history of blurry vision in the right eye. His vision active was 660 in the right eye, 6/9 in the left. He has mild non-progressive diabetic retinopathy and right macular edema. Although MP scan doesn't look that bad, but maybe that fluid in the ellipsoid area is affecting his vision significantly. I gave him ranibizumab in the right eye, vision improved 6/18, and diabetic macular edema improved on OCT. And I gave him another injection, and vision improved to 6/9, and that was his OCT after the second injection. So I usually don't go ahead with loading dose in diabetic patients. Once the vision improved 6/6 and macular resolved, I stop and just keep them follow. Thank you very much. I'm sorry it was a longer talk, maybe than expected. This late in the evening. Thank you very much.
Thank you so much, Dr. Firas, for this nice talk about diabetic retinopathy. And regarding my opinion about laser treatment and anti-VEGF, still I do laser for those patients because unfortunately those patients can miss follow-up. And sometimes they go disappear for 3-4 months and they came back with a disaster. So I like to secure the eye with the PRP treatment for those patients. And unfortunately, we are running out of time, and I think we will conclude our presentation now. So we'll give the next session the time to start on time. Thank you, Dr. Firas, and thank you, Novartis and Qasimi, for this opportunity.
Thank you very much. Thanks, everybody. Thanks, Dr. Muhammad. Assalamu alaikum.
Salam. Thank you, Dr. Noura and Dr. Firas. Thank you.